I'm Kristen here at UT Southwestern Medical Center. I am thrilled that you're joining us for our chat on pancreatic cancer as part of Pancreatic Cancer Awareness Month. Today we're going to be joined by surgical oncologist John Mansour and diagnostic radiologist Gaurav Khatri. So I want to thank you both for being here today.
Thanks for having us.
Thank you for having us.
Absolutely, it should be a great discussion. Definitely want to make sure before we get started that, as usual, remember that we can't answer your specific medical question about your cancer, but we can certainly answer all the general questions that you have, and we're happy to do so. And we also, before we get started, obviously we want to thank our departments of surgery and radiology and radiation oncology and the Simmons Comprehensive Cancer Center, as well as Moncrief Cancer Institute for helping us push out this chat. We hope you heard it out from one of those vehicles. And so we'll go ahead and get started. I want to start with a very simple question that for one of you, and that is, what is the pancreas and what is its function? What does it do for us?
Right, so we get that question a lot. Patients are always interested. It's not the kind of thing that people think about very often, unless you do what Dr. Patrick and I do. And so I think the simplest way to understand this is the pancreas does really two things. It helps with controlling blood sugar, insulin and glucose, that sort of thing. And then it helps with digestion. It makes enzymes and juices, and it's plugged in, sort of a little side branch of our GI tract, and it puts those enzymes in there and helps us digest our food.
Okay, so then is it, moving on to, you have pancreatic cancer, is it something that can be prevented?
Right, that's a big question, and that's something actually that Gaurav and I work together quite a bit. We have a couple programs that work together on that, and I'll let you take the second part. But I think we don't really know ways to prevent pancreas cancer other than basic things like smoking seems to be a risk factor, obesity seems to be a risk factor. But then I think a much more active piece of this is identifying people who are at great risk for pancreas cancer, whether due to some genetic predisposition, I can talk about what those genes are if you like, or to certain findings we see in their pancreas, particularly cysts that may predispose them to cancer.
Yeah, that's a great segue into what I can expand upon. So, as John mentioned, there is a subset of population of people that may be at higher risk for pancreatic cancer, and typically those patients are identified through genetic testing, or are identified, they may have a CT for some other reason, for example, and they may find a small abnormality in the pancreas, such as a pancreatic cyst. And so there is some data that shows these patients may have increased risk for pancreatic cancer later on. So what we can do is we can image these patients either with CT or MRI over time, which allows us to assess for changes in those lesions and hopefully catch them before they become pancreatic cancer.
Gotcha.
I think it's actually a really important thing to stress, because a concept of stress, and the way I explain this to people is it's very much like mammograms and colonoscopies. We've identified groups of people who are at increased risk of getting breast cancer and colon cancer, and we survey them with a test. This is really, in many ways, exactly like that.
Interesting.
And we have a program that helps people do that, our pancreas cancer prevention program.
Interesting. So before we go any further, as a radiologist, what do you do to assess risk for pancreatic cancer?
Yeah. So as I mentioned earlier, one of the things that we do is we read so many CT scans of the abdomen, which is where the pancreas is, and oftentimes we may come across incidentally an abnormality in the pancreas, which may then be identified as a pancreatic cyst. And then what we can do is we can evaluate that cyst further with dedicated imaging for that cyst, either with CT or MRI. MRI seems to be a little better tool in assessing the characteristics of pancreatic cysts, and in doing so we can assess if that cyst is pre-malignant or has a risk for going on to becoming cancer or not, and catch it hopefully before it becomes cancer.
Okay, that makes sense. So we're starting to get some questions in here, and this first one, we started to touch on it a little bit, but Cece, she says, I've heard that there are two types of pancreatic cancer. What are they and how common are they? Are there two types?
Yeah, there are. That's a good question, and it's really something important to mention because they're very, very different. So one type of pancreas cancer, which is much less common, is something called pancreas neuroendocrine tumor. And although that's a very serious cancer, and people do lose their lives to pancreas neuroendocrine tumors, it's not nearly as aggressive as the much more common type of pancreas cancer, which is pancreas adenocarcinoma. And so I would say that the two types are pancreas adenocarcinoma and pancreas neuroendocrine tumor, CC, and they do behave very, very differently. The treatments are totally different. The prognosis is very different. They look different to our radiologists, and it's one of the really terrific places where our radiologists can make a difference. They can tell the difference just with a scan in many situations. And so getting that information, which type do you have, is probably one of the most important first steps you can ask, because it's just not the same.
So you mentioned scans.
Right.
I don't mean to cut you off. If you
No, that's great.
No, you mentioned scans, and I'm curious, are they all the same? If you get one scan, does it tell you the same thing as the other scan?
That's a great question. I can tackle that one.
Yeah.
So when John says scans, he means any kind of imaging of the pancreas. And there's different types of imaging modalities or techniques you can use. Those include CT scans, which are probably the most common in this setting. And CT scans use X-ray beams to make images of the abdomen or whichever part of the body that you're interested in. It's a very, very good and robust technique. There's an MRI scan, which does not use radiation. That's a common misconception between, the differentiation between MRI and CT. MRI does not use radiation. And so MRI is a little bit more complex in the way it's done. So it's a longer test. In some cases, it can give us more information about the pancreas than CT scans can. And so for a lot of our patients in the pancreas cancer prevention program, we do surveillance, as John mentioned, with MRIs either every 6 months or every year to assess for changes in those cysts. There's also something called a PET scan, which is a completely different type of imaging or scan. Basically, it's looking at metabolism of the pancreas or of lesions, and typically it does not have quite a large role in the setting of pancreas cancer.
Okay.
Yeah.
So what are the signs and symptoms people should look for? It's my understanding that pancreatic cancer is more difficult to detect.
Correct. So one of the challenges of pancreas cancer for patients with pancreas cancer is that the vast majority of people with pancreas cancer are diagnosed when the cancer has already spread. And the signs and symptoms of early pancreas cancer are just not well worked out. We don't know. We catch it too late, for lack of a better way to put it. Some of those symptoms are things like pain and weight loss and having your eyes go yellow. We call it jaundice. But the truth is that relying on those symptoms and even people to catch those symptoms and just come right to their doctor probably isn't soon enough. And it's one of the scary things about pancreas cancer. And many people are maybe listening to this or watching this and thinking, yeah, I didn't really have many warning signs. And that's very common. It's unfortunate, but it's true.
And if I may add to that, as John said, this is why pancreatic cancer is typically caught late. Is because those signs and symptoms are so poor and typically occur late in the disease. And this is for pancreatic adenocarcinoma, by the way. So, and that's also precisely why, if patients have any kind of genetic risk factors or family history of other people in the family having pancreatic cancer, it's probably a good idea to go to a program such as ours, which is a pancreatic cancer prevention program, to see if you have the genes that place you at risk, if you have other findings of the pancreas that may place you at risk of developing pancreas cancer, so we can image you and catch you early.
That's a perfect segue to this next question that we got from Kevin, and that is, what role does genetics play in pancreas cancer prevention?
Right. So there are two elements to that question, Kevin. So the first is, do you have, does a patient or does a person have syndrome, a gene we know is mutated. So a good example of this is BRCA, BRCA1 and BRCA2. We commonly think of those as genes associated with breast cancer, right? We know that a lot, it's really common. But patients with mutations in BRCA1 and 2 also have increased risk of pancreas cancer. So there are many genes, and I can, ATM, PALB2, we know lots of genes that put patients at increased risk of pancreas cancer. But the other sort of side to that answer is what Dr. Khatri mentioned, which is just good old-fashioned family history. So for instance, we know that if you're a person in the United States who lives to the age of 80, and you have no family history, your chance of getting pancreas cancer is 1%. 1%.
That seems pretty small.
So if you have one first-degree relative, it's about 1%. It's not that much higher, but it goes up fast. So if you have 2 family first-degree relatives with a history of pancreas cancer, it becomes somewhere around 8 to 10%. 3 family first-degree relatives, it becomes something around 30 times higher. So it really goes fast. So I think I wouldn't just, knowing your family history, knowing, kind of whether there's pancreas cancer in there is as critical a detail as whether you have a particular mutation or not. And that's part of what, I think a good program should be looking at.
Okay, good to know. So we've got another question here for Ellen. I think this is also for you, Dr. Mansour, and then we've got one, and then I'm going to talk to you about Dr. Khatri. What are the currently available treatment options for pancreas cancer?
Right. It depends a lot on where the cancer is, and I don't mean where within the pancreas, but it leads us to this question of what's your stage, how's staging work, and I think that the simplest way to think about it is whether your cancer has spread outside the pancreas to other organs, like the lungs or the liver, or whether it has not.
Okay.
If it's spread to other organs, the only treatment we have for patients is chemotherapy or immunotherapy, is some systemic therapy. And unfortunately, in those situations, it's just not a curative therapy. We're trying to just help people live longer, better lives. In those patients where it hasn't spread to the lungs or the liver or somewhere else, then we do still very, very frequently use chemotherapy. We do. It's really a very important part of what we do, and I think it absolutely helps people live longer and reduce their risk of recurrence. But also surgery, and that's obviously something that we do. The surgery is very complicated. We can talk about that if people want to hear about it. But radiation plays a role in it, in some of this therapy. But I think it's really surgery and chemotherapy and knowing whether your tumor has spread or not. Those are the key details.
Okay. Really good question. Thanks for
That's a
bringing
great
it up.
question.
So one of the things that you mentioned when you were talking was staging, and that definitely enters into your arena, Dr. Khatri. So when you go to your physician and they say, "I want you to get staged," that sounds a little scary.
Sure.
What does it actually mean?
Right. It's so what staging means is to try to figure out if the pancreas cancer has spread anywhere else in the body or not. So typically, staging of pancreatic cancer is done by getting CT of areas distant from the pancreas, right? So you would get a CT of the chest potentially, right? You would get a CT of the abdomen, of the pelvis. You would include the liver. Those are all sites that commonly we see spread from pancreas cancer to go to. And so CT is probably the most common modality or imaging scan used to stage pancreatic cancer to look for spread outside of the pancreas.
Okay, and are there any side effects that individuals should look for as a result of just those scans?
There would not be a side effect of the scans themselves.
Okay.
CT scans these days are done very fast, and we usually give what's called identity contrast, which over the course of time have become very mainstream, and rarely do they ever have any side effects. Some people can experience nausea or a warmth when they get the contrast agent, but it's not a negative effect. Now, there are a subset of patients just like anything else, just like any medication, if you have an allergy to the contrast, then we can try to use different contrast agents, or potentially use an MRI instead of a CT in the appropriate setting, where we can move away from those side effects or potential reactions.
Okay.
Yeah, if I could add one element about staging, staging is so critical, and one of the key points I like to stress with patients and their families is you really can't start a treatment plan until you have been adequately staged. It's an incredibly important thing. People want to get started on their treatment, and I understand that, but you can't. It's unsafe and it's unwise. You need to know what your stage is before you take that first step in treatment.
Okay.
So that's a really critical aspect of this.
Okay.
Doing it right, doing it well.
Okay, good to know. So that was a great question. Thanks for bringing it up. Here's one from Claire, and her question is, who is at risk for pancreatic cancer?
Right. It's I sigh a little bit because I think the answer, which I don't mean to be sort of dismissive, we all are. 1% of us in the United States can get pancreas cancer, and yes, it's true that incidence goes up as we get older. No question. We see much more pancreas cancer in patients who are 60, 70, and 80 than we do in patients who are 20, 30, and 40. So age is a factor there. Family history is absolutely critical. We've talked about that. Being overweight and smoking seem to be risk factors. But part of the reason I sort of hesitated before I answer that is the vast majority of patients who we see with pancreas cancer aren't obese and didn't smoke and don't have a family history. So although those are really important elements and we use them in our surveillance strategies, unfortunately it's not so simple as to say, well, I'm negative on all of those, so I'm probably in the clear. And I don't want people to be afraid of it, but I just think there are a lot of people who don't have very many risk factors and yet still get pancreas cancer. And we're working very hard, us and other investigators, to try to understand that, but we're not there. We don't understand why that happens.
Okay, good question, Claire.
Yeah.
So we didn't have better news.
Yeah.
Here's a different question, and so if somebody has been, it's from Ellen. So if somebody has been diagnosed with pancreatic cancer, are there any lifestyle changes that they should anticipate or plan for, that they need to make as a result of pancreatic?
As a result of having pancreas cancer?
Mm-hmm.
They're treatment related. Mm-hmm. So if a person, for instance, has a pancreas cancer and they undergo a very common operation for patients with pancreas cancer, which is called a Whipple.
Mm-hmm.
Whipple. It's a much longer name, which probably won't translate well to this forum, but Whipple is a common
Whipple is good.
And patients who have that operation do return to a relatively normal life. They work and they take trips and all, but it's not, the way they eat is a little different, their appetite is a little different, they may lose some weight. So there are changes that are associated with these therapies. It's definitely true for chemotherapy as well. When patients get chemotherapy, they may experience some fatigue, it may wear them down a little bit. If Ellen's question is, what do we tell people, what advice can we give people who are trying to fight pancreas cancer, going through this journey now? What advice do we tell them about lifestyle to get them to maybe take this on? I think it's really about being healthy, and the more healthy you are when you take on any opponent, I think the stronger you're going to be. So I strongly encourage people to have really good, strong, basic nutritional principles, eat a balanced diet, all those things, to try to stay active. And I think just maybe as importantly, to try to keep your mind and your social life active. They're really critical components that we often ignore in medicine. So things like staying intellectually active at work if you're still working, or with whatever projects you like to take on, and trying to stay socially active, trying to keep those networks together. We oftentimes let that go. That really is vital to get through this. So those 4 aspects of health.
Yeah,
shaking your head.
I was going to say, as doctors, we sometimes maybe don't emphasize that quite as much, but I think it's very, very important. you really have to have a strong network, family and friends, and keep engaged socially as much as you can, in order to be able to get through something like that. So that's really important.
All right, thanks for bringing that up, Ellen. That was a great discussion point. So here's a different one from RC, and this is about metastasizing. If a patient has been diagnosed with stage 4 cancer, what is the likelihood that it can metastasize to the pancreas versus other areas of the body?
Yeah. So that's a term that people ask about a lot. Stage 4 cancer. Is my cancer stage 4? And what stage 4 means in pancreas cancer, it's different in other kinds of cancer, but what stage 4 means is that the cancer is no longer just confined to the pancreas, but pancreas cancer cells have spread somewhere else. So if it spreads to the liver, for instance, that doesn't mean you have liver cancer. It means you have metastatic stage 4 pancreas cancer. And so I think that concept is really important, what stage 4 cancer means.
And on the scan, on imaging, we're looking for an abnormality in the liver in somebody who has known pancreatic cancer, and that's how we determine if it's, it's one of the ways to determine or suspect that it's spread outside the pancreas. That's why getting the CT scan or MRI is really important, and appropriate staging is very important with imaging.
Okay.
And when it's, to complete that thought, because I'm sure I haven't been asked, someone's thinking, because we get asked this a lot in the clinic. When a cancer has spread, when a patient has a stage 4 cancer, we now really need to focus less on sort of very focused treatments just to the pancreas or just the liver. We need treatments like systemic chemotherapy or immunotherapy, which go all throughout the body, not are just focused on what we see. And that's why people ask a lot, can you just go cut out all the spots that you see? That's not effective. That's been looked at more by other investigators. It's really about getting you treatment that goes to your entire body through your bloodstream.
Okay. So we've got three-part different questions we've gone from Rob and Crystal, so we're going to try to get to them. But I want to start with this one. This is, I think, maybe the quickest one to answer. Crystal asked 2 questions. What is the mortality rate for pancreatic cancer? And then, are certain ethnicities more likely to develop it? We touched on genetics from familial, but is your ethnicity also a factor?
Yeah. Ethnicity is not a very strong predictor. I mean, there are some small little subgroups, but it's not a very strong predictive factor. The tough question about survival, that's a really hard question. And it depends very much on whether the tumor can be removed or whether it cannot. So has it spread or has it not? And the answer is very different. So for patients whose cancer has spread, you'll hear these numbers thrown about, and I think for any patient talking about any type of cancer, it's important to understand this. We throw around a term called median survival or average survival, and that means at what time are half patients still surviving? At about a little less than 2 years, about half the patients are still surviving if it's spread. That number is going up a little. We have more new therapies, and the number on that dial didn't change very much for a very long time. We're starting to move that dial. For people who can have their cancer removed, it's different. It's still not where we want to be, but it's different. So, and I put the answer in a little bit of different terms. Yeah. If you can have it removed, if you look out about 5 years or so from the time of your surgery, about 30% of patients will still be living without cancer, which you can see those numbers are very different. So knowing whether the tumors, we keep getting back and I keep stressing this concept of staging. If it's spread, if it's stage 4, it's a much lower survival than if it can be removed. It's more localized.
So
sobering numbers for sure.
Very sobering numbers. We've got 2 two more questions here. This one's from Rob, and I just want to remember everybody, we can't address your very specific questions, but I'm going to go ahead and read this because I think there's some general ways we can talk about it. And it's after a successful Whipple with clean margins after diagnosis with stage 1B pancreatic cancer in the head of the pancreas, what is the recommended treatment with chemotherapy, or is it better to monitor closely? Is there anything there that seems?
So there are a couple other, I think that's an okay thing to talk about. I think there's some key pathologic details that may be important. So, how clean was your margin? How many lymph nodes were looked at? If they looked at 5 lymph nodes and they were negative, that's okay. But if they looked at 35 lymph nodes and they were negative, that's much more encouraging. We think that's a much more favorable thing. And there are also some little details in the pathology. Are the nerves involved, or the little lymphatic channels involved? So that helps us decide. I think as our chemotherapy has become more effective for pancreas cancer in the last few years, last sort of 5 to 10 years, it's really pretty uncommon that we don't recommend some form of chemotherapy after resection. So in other words, say it in a different way, we almost always recommend that people get chemotherapy after a good resection. We just haven't found that population of patients who, this is once again a little sobering, but we haven't found that population of patients where we can say, you're in the clear. You don't need anything else. We worry about everybody. Even people who have that kind of favorable response, I'm really happy to hear that. We generally think it's useful to put something out there.
Okay. All right. So we are literally running out of time. We've got about 2 minutes, but here's a question that Shannon posted, and she asked, she joined a bit late, wanted to know if we discussed genetic mutations and pancreatic cancer surveillance. I believe you mentioned something related to that,
Yes.
Dr. Khatri?
Yes. So as Dr. Mansour mentioned earlier, there's a number of genes that can be looked at to assess if a patient is at risk for pancreatic cancer. In addition, it's important to know if there's a family history, anybody else in the family who had pancreatic cancer. Now, if that is the case, or if there are genetic mutations, we can do imaging either with CT or MRI. Here we tend to use MRI because of a number of reasons. To assess the pancreas, we do specific imaging of the pancreas that will help us look for lesions very, very early on. So potentially even before they become cancer. And so that's one of the things that we're doing here in some of these patients that are at risk.
Okay, that sounds great. Really great question. Thank you for asking and for tuning in. We appreciate it. All right, last question. And what advice, and this is for both of you, what advice do you give people when they're trying to find a team of physicians? Let's start with you, Dr. Khatri.
Yeah, that's a great question. So it's really important that you go someplace that actually has a team that works together. And we're fortunate here at UT Southwestern that we actually have that. We have a pancreas cancer prevention program, and what that means is we have a program where the surgeons, the oncologists, the gastroenterologists, the radiologists, all of us work together. We're on the same page. We know what we're looking for, what we're targeting, and what are the questions that need to be answered, either by the clinical history, by the imaging. We tailor our imaging techniques to answer the questions that John and his team pose to us. So it's very important that there's crosstalk and the entire team is on the same page, assessing a patient's complete risk for pancreatic cancer.
Okay. So add
I think that's critical. The team concept and the experience concept is this. Do you have people, are you seeing people who this is what they do? Or is this something they do in addition to 20 other things? And the one thing I like to stress to patients and their families is that this is complex care, and your outcome is determined. Yeah, sure, it's determined by your medical oncologist and your surgeon and your radiologist and your pathologist, but it's determined by your genetic counselor and the nurse who takes care of you in infusion and on the floor and your physical therapist. And so, having a team of people that this is just they're experts in this. There aren't many people. There aren't many surgeons who have the luxury of working with a radiologist who's an expert in MRI imaging of the pancreas. I mean, that's a very narrow field, but I am. And so I think that having a team of people like Gaurav and others in other disciplines, you just can't underestimate the impact that has on a patient.
Awesome, great question. That's a perfect way to end, because we are all out of time. It's been half an hour, I think a little bit over. I want to thank everybody for all the great questions. Don't forget, this will be available here on our Facebook page, and we'll also post it on our YouTube channel later today. So if you have friends that aren't on Facebook and want to see it, please send them the link. It's really great information. And mainly, I want to thank you two for joining us. It's been a pleasure.
It's an honor to be here. Thank
nice
you.
to chat with you as always.
Thanks for having us.
And we're going to call it a day. So thanks for tuning in.
Thank you. Have a good day.